Good day, these great surgeons. Today we're gonna talk about a very interesting yet critical topic in our life and in our exam, especially in MRCS, the breast chapter. It's very important to be familiar with the breast. It's overlapping with the endocrine, but for me, breast is the best and the breast is a separate chapter. So let's dig this chapter together. Together we can. To be familiar with the breast and MRCS scope, you have to be focusing regarding the management of the breast cancer, the screening of breast and breast cancer, the age of the screening, the modality of the screening, and how to screen. Follow the guideline. Whatever is done in your country is not we are asking about. We are asking about the regulations and the guidelines regarding the breast cancer in UK. So take care. This is a big trick, as well as the management differs in UK than any other country. There is a broad line. They are following guidelines. I know many countries have their own guidelines. That's why we stress on it. Together we can. Dear great surgeon, a very common scenario to have in the exam is a female patient presenting to the clinic with a tender, hot breast. Please ask this patient if she is married or not. This is not because you are a single doctor asking her for marriage. You are asking her marital status to know the incidence of this mastitis, the incidence of this breast abscess is due to a normal breast abscess, or is this impending course that is masked by the mastitis, like the mastitis carcinomatosis. A married woman who is pregnant or lactating, she will be probably having engorgement of the breast because of not enough lactation of her child or not enough pumping of the milk and the stationary and the engorgement of the milk within her breast. That means the stasis become an abscess. The milk become an abscess because she refused to give her son her milk to be a pretty lady. So she was punished by having a breast abscess for not even pumping her own breast milk. But if she wasn't married, or she is married and not lactating, and having a breast abscess, she is not this lucky lady. There must be a predisposing factor to have an abscess, like immunosuppression, even diabetic, or low immunity, or having bunched in the breast and with the foreign body. There must be a predisposing factor to have a normal abscess. But without any predisposing factor, a breast abscess, this is not common at all. Even the perineal abscess have a predisposing factor, and it's more common to happen without any factor either due to poor hygiene. But a breast abscess, everyone cares for his breast, even the man. So this is mastitis carcinomatosis until proven otherwise. So the trick regarding the normal abscess is to know, is it an abscess of the breast required drainage, or it's an abscess of the breast required drainage and taking biopsy from the bone because it's mastitis carcinomatosis. By the way, the mastitis carcinomatosis is very poor prognosis, not only because it's aggressive in itself, but as well it's discovered late because many doesn't put the mastitis carcinomatosis in its differential and doesn't ask the patient for its marital status as if he is going to marry her. No, you are not marrying any patient coming to your clinic. If you're having a breast clinic, what will you do? You will marry all the women coming to your clinic? No. You are asking them a professional question. Dearest lady, are you married? Because I want to know the incidence of what is happening to you and to understand the physiological changes in your body. This is the whole thing, is what it's all about. So that's the importance of the history. So please ask your patient for the history. Don't do like the orthopedic surgeons. I have a fracture. I need to fix it. I have an abscess. I have to drain it. No, you are dealing with a patient. Ask him for the history. Examine. Don't go with your scalpel before your mind. And during your differential sequelae, you have some areas in your body where there is no weight for fluctuation. So, if a patient comes to you with a hand infection, parotid abscess, breast abscess, buttock abscess, perianal abscess, perinephric abscess, airy P abscess, so go for excision and drainage. There is no waiting for fluctuation in those P areas. They all start with a P. The pulp space, palm space, parotid abscess, breast abscess, buttock abscess. The buttock abscess is the gluteal abscess. We said buttock to make it familiar with you, but it's called gluteal abscess. The perianal abscess, perinephric abscess, every P abscess must be drained. Take care. Good question coming. Is mastitis carcinomatosis can occur also in a pregnant or a lactating female? Unfortunately, yes. But let's talk about the incidence. It will be resistant abscess. If a female lady coming to you, she is pregnant or lactating and coming to you with a resistant breast abscess, you have drained it 1 and 2 and 3 times. What is this? Of course, you are a junior doctor, are trying to help the patient, but not too junior that you can't drain the breast abscess and you have to drain it 3 times. There is a problem with this patient. Think for it. There is another differential for the breast abscess. It's carcinomatosis. It's mastitis carcinomatosis. And by the way, take care. We have 2 areas in our bodies. The pathologies are more common in females, the thyroid and the breast. Any swelling in the thyroid or the breast in a female is common to be differentiated. But in male, any swelling or an abscess within thyroid or a breast are cancerous. They are a big deal. It's not normal to have a man with a thyroid swelling. It's cancer until proven otherwise. There is no man have a breast swelling. It's cancer until proven otherwise. And by the way, having gynecomastia is not a tumor. It's a hormonal disturbance. We have to deal with it. And thanks to plastic surgeons, they can now carve the body and make it muscular with only redistribution of the fat. So if anyone have gynecomastia, it's now treated with liposuction and body contouring. I am always will be there for every man to make him a 6-pack and no one will notice it. Consider it like commercial or advertising. I have the right to do it. It's my group. So every man has the right to have an enlarged breast, but not to have a breast mass. There's a big deal if a man have a breast mass. And the disc felt in the gynecomastia is not a mass. It's a disc. It's a gland hypertrophy. But don't confuse a mass with a swelling. The swelling in a breast mass of a man is a big deal and precancerous. But in female, we have to differentiate it. And always remember that the female have a breast in her mouth. It has a mouse in her breast. This is the most common swelling in every female breast. And it's normal and no big deal. Don't remove the mouse from any female breast unless it's changing its behavior. If the mouse is cute and doesn't do anything wrong and amusing herself with this mass, don't confuse this amusement. Keep it with her. Don't kill the mouse. Keep the breast mouse. But if the mouse didn't behave and become attached to a certain place, doesn't move, is not smooth, so it's not amusing anybody to have a tough thing in his chest. So remove this swelling if it's annoying the patient. This is the indication for breast mouse removal. So what is this mouse called scientifically? The breast mouse we are talking about is a fibroadenoma. Under the age of 25, the breast is usually classified as undergoing development. The lobular units are being formed and a dense stroma is formed within the breast tissue. This may result in the development of fibroadenomas. So This is a normal mouse, funny mouse, in the female breast. As a group, fibroadenoma account for 13% of all palpable breast lesions. And by the way, fibroadenoma account for 60% of the discrete breast lesion in the age from 18 to 25 year age group. They are mobile lesion. The core biopsy should be performed in the lesion measuring more than 4 cm in diameter, but less than 4 cm of diameter, no big deal. So it's a funny, cute mouse. Keep it, no worries from it until it changes its behavior. The fibroadenoma classified as juvenile, common and giant. The juvenile occur in early adolescence, and the giant is characterized to be a size greater than 4 cm. In young female with small fibroadenomas less than 3 cm on imaging, a policy of watchful waiting without biopsy may be adopted as we agreed. So nothing to do if the fibroadenoma below 3 cm. And if the size greater than 4 cm, this will attract the recommendation for a core biopsy to exclude phylloid tumor. And remember, we all agree that phylloid tumor in the exam will presenting with a fast growing swelling in the breast. This is cystosarcoma phylloids. It's not a cyst, it's not a phylloid, it's not a sarcoma either. And by the way, it's benign. And a probe test is done to make sure that it's separated from the chest wall and it's not cancerous and rarely turn malignant. So the phylloid tumor, benign, fast-growing swelling within the breast. Do you remember a skin lesion that is fast growing? Gets great? Those are the keratoacanthomas. They are fast growing solitary cutaneous neoplasms that usually show spontaneous regression. They are self-limited most probably, rarely turn malignant. It can predispose to a cancer, but in itself it's not a cancer, it's a benign, the keratoacanthoma. Keep it in mind. So, in the skin lesion, a fast growing swelling will be the keratoacanthoma wherever it takes, and the fibroadenoma is a normal small swelling, while the cystosarcoma phylloids will be fast enlargement of swelling in the breast. It's benign, like the keratoacanthoma. Isn't medicine is amazing? And by the way, the fibroadenoma doesn't change in size. The fibroadenoma doesn't change in size. Because if a female came to you with a cyclic mass changing in size, this is, yes, fibrocystic disease. The fibrocystic disease of the breast is changing in size and changing in the pattern with every cycle because it's hormonal affected. With every cycle, she will tell you, oh my doctor, I have a swelling in my breast. It's tender and it enlarges in size with each cycle in my period. What is this? You tell her, no worries, dearest girl. You are a pretty lady having growing up issues because you are becoming a lady. This is fibrocystic disease of the breast and nothing to deal with it. It's good. No worries. Tell your patient to take primrose oil and a push-up bra and she will be good. Nothing done to the fibrocystic disease of the breast. Ensure your patient. What if a patient came to you with a discharge coming out of her breast? The type of the discharge will be differentiating your differential diagnosis. So keep in mind, is it a bloody discharge or a creamy discharge? If it's a bloody discharge and she is a young lady, the most common cause for a bloody discharge or bleeding per nipple is the duct papilloma, and it's treated with microdocutomy. While if she having a milky, creamy secretion or greenish ether, she will be most probably smoker patient, and this is a ductictasia at age of 40. But if a patient came to you With a milk, it might be an abscess. Take care. Not every white secretion in a lactating lady is a milk, especially if it's tender. So take care. Is it a milk or is it an abscess? Because the most common discharge in general from breast is the milk. The breast was made to give milk to people. That's why we are all here. We all, thank God, have had lactation to be a healthy human beings. So is it an abscess or is it a milk? The examination of the breast and examination of the fluid is very important to know the nature of this discharge. So the bleeding per nipple in young lady will be most probably from duct papilloma and will be managed with microdochiotomy, while the creamy discharge due to ductictasia, which will be managed with major duct excision like the Hatfield operation. And if it was an abscess, never wait for fluctuation, incision and drainage. There is no waiting for fluctuation in breast. Breast is pretty important. And give the patient the instruction to care for her breast. Is there any benign lesion that can confuse us with cancer in the breast? Yes. Any lady, like any human being in this world, can get hit in any part of his body. But unfortunately, the females are very smooth creatures. They weren't made to be hit by any simple mean. So a simple hit to a breast can cause a fat necrosis, which can mimic a breast cancer that might get the patient worried and get you even worried. And this will be differentiated by the history and the biopsy. It will be denoting this is a fat necrosis. In the exam, he won't tell you the fat necrosis saponification event, but tell you about the age of the patient. She will be young, having a firm mass in her breast, but had an event of being punished. I don't know why someone could punish any lady. It is not normal at all, especially in our countries. Right? Am I right or not? Please deal with the ladies as a queens. The lady is our mother, our sister, and our daughter. Take care. And as we agreed in the thyroid with the triple assessment is specially made for the breast swelling. History and examination, imaging with ultrasound or mammography, or even MRI if needed, and we will talk about it when to use MRI in our breast lesions, and of course biopsy. So history and examination, this is a part of your assessment, as we told. Most of the previous scenarios depend on the history. Then the imaging, then the last thing will be the core biopsy. Now let's trick you regarding a very famous trick in the exam about a male breast. A male patient, not a female. Take care. That's why the gender is important. A male patient presenting with bilateral gynecomastia. We all agree that gynecomastia is hormonal disturbance or pubertal growth. So, he is not presenting only with gynecomastia at 19 years old, but he has a poor vision and nipple discharge. There is no gynecomastia in a male with a nipple discharge. So, what test could you do for this patient to ensure the cause for this presentation? The gynecomastia, poor vision, and the nipple discharge. Of course, prolactin. This is most probably a prolactinoma, a combination of nipple discharge and gynecomastia with a poor vision. This is prolactinoma. This patient won't need the liposuction of the gynecomastia. He will have to deal with the prolactinoma at first. Take care. The poor vision of this patient is from the compression of the optic chiasm, resulting in bitemporal hemianopia. Gynecomastia describes abnormal amount of breast tissue in male. There is no female with gynecomastia, by the way. It's normal to have a female with two breasts. It's a gender confirmation. While the gender affirmation is changing from gender to a gender and creating a breast in a male, like a very famous actress who changes her gender from female to be a male lately. She removed her breast and created her gender to be a male. The famous actress of the X-Men, if you can remember. She was playing Mystique. So regarding the gynecomastia, it's abnormal amount of breast tissue in male again, and usually caused by increased estrogen to androgen ratio. Both the male and female have estrogen and androgen. It's not because a man is androgen doesn't have an estrogen. No, he will have an estrogen. And female doesn't mean that she doesn't have an androgen. No, there is estrogen-androgen ratio different from male to female. It's important to differentiate the cause of the galactorrhea if it present in male due to the action of prolactin on breast tissue from those of gynecomastia. So, galactorrhea is an abnormal discharge in male breast who are having gynecomastia. Gynecomastia in itself doesn't be having galactorrhea. So what are the causes of gynecomastia? There are physiological causes and pathological causes. The physiological causes will be a normal presentation during puberty. So if a male during his puberty came to us with gynecomastia, there are grades for gynecomastia. You are not meant to know it for MRCS scope, but we will reassure our patient and give him a support that he is a man and a strong man. There is no worries. You can grow up a six-packs and do pectoral sports and you will be a sportive man. It's normal to have this mild gynecomastia grade. This is physiologically dear. But take care. If this an underlying cause like syndromatic with androgen deficiency like Kalman or Klinefelter, keep this in mind. A poor patient with testicular failure due to mumps, he didn't take his mump vaccine and get a testicular failure and didn't have his androgen enough and the testosterone and got gynecomastia. This will be our sister. This man will be our sister. And not even a man or not even a sister. And will get a gynecomastia. So we will support him and treat the gynecomastia at this point. He had a liver disease, like the famous singer Abdul Halim Hafiz. His hair become more smooth. His voice becomes so soft because due to bilharziasis, he had a liver failure. This caused the estrogen to increase and the estrogen become dominant, doesn't distract in the liver due to the liver disease. So he becomes smooth with a pretty hair and pretty faces due to the estrogen effect and get a gynecomastia. This is not a funny thing at all. A testicular cancer, the same effect of the mumps. This will be a seminoma secreting HCG. That's why in testicular carcinoma, we will do a pregnancy test for the patient. For a prostate cancer, you can get a pregnancy test for the man. It's not funny. We are not doing a pregnancy test to expect a man pregnant. Even in this terrifying ages, we have men who are seeking to be pregnant unlike their nature. I don't know why, but a testicular cancer is searched for by the HCG. Ectopic tumor secreting estrogen, hyperthyroidism, hemodialysis, and many drugs that can cause gynecomastia, like spironolactone. Many use spironolactone as as a diuretic. So spironolactone is a famous diuretic used in hypertensive. Many men fear that spironolactone because they say, I will withstand hypertension, but I want to withstand to have a gynecomastia. Many take cimetidine. Many have heart failure. I will stand my heart to be failed, but I want to take digoxin. You would say to him, it's not a choice. It's either your heart or your breast. He will say, my breast. This is the man. But the female will be happy to have a heart failure and take the digoxin. Remember this. But save this patient and give him digoxin and tell him we will do the gynecomastia operation for you and do a liposuction with Dr. Bishoy. Recommend me and I will be glad and I will give you percentage. It's a big deal and we can do it together. So, spironolactone, cimetidine, digoxin, cannabine, and finasteride, even estrogen, anabolic steroids can cause all gynecomastia. And very rare drugs that can cause gynecomastia, like tricyclics and isoniazide, as well as the calcium channel blockers, heroin. Don't take heroin unless you want to have gynecomastia. That's why we say no to addiction, because it can cause gynecomastia. So don't take heroin and the cannabis. It can cause gynecomastia. Even the methyl dopa. So the aim from all of this is to put your hand on the cause of the gynecomastia. We are not treating a breast, we are treating a patient. Put your hand on the underlying cause for the gynecomastia. Just as we care for the pretty lady to have a healthy breast, we care for the male person to have a well-being life. Understand his cause for the situation he having a gynecomastia. Yes, we will do liposuction and provide you the best cosmetic outcome and do a body contouring for your breast. But we have to identify and manage the underlying cause for this gynecomastia. I'm sure from all the voice notes you have hearing now, every boy is caring for Angelina Jolie prophylactic bilateral mastectomy for the BRCA genes, and for Ellen, the X-Men Mystique, who became a boy. I know this destroyed all your childhood and your adulthood love stories with the actress. Be grown up. You are a surgeon. There is no time for love. There is time for surgery. So let's go on, complete our breast chapter together. Someone is asking if there is no time for love for a surgeon. No, you can always love your surgery. You can always love your scalpel. You can love your instruments. You can love your science. You can love your roommates in the hospital. We are a family. We are like a monks of surgery. Do you know why surgeons will go to the paradise? Because they have no time to do mistakes like normal beings. Embrace yourself. Be happy. You will go to the paradise. Amen. Dear great surgeon, take care. There is a big difference between a breast lump assessment and population screening. Population breast cancer screening starts at the age of 30, and screening means mammogram. We only use MRI for screening if there is a strong family history with breast cancer. This is the only exception for the word screening, to use anything other than the mammogram, and you will use the MRI. So in the exam, if you read the word screening, don't be confused. It's mammogram unless there is a strong family history. It will be MRI, whatever the age, because it's a high risk group. But if we are talking about the lump assessment, it will follow the triple assessment rule, where there is a history and examination, investigation, as well as will be a biopsy. And regarding the imaging technique will be different according to the situation of the breast. Is this a young lady or an old lady? And the cutoff age will be 30. Is this a young lady? Go for ultrasound. If this is an old lady, go for mammogram. We are talking here about the lump. But if this patient or this female or this lady having a breast implant, a silicone breast implant with a swelling, how to investigate a lump when the patient having a breast implant? Take care in the exam. Is he asking you to assess the condition of the lump or the breast implant? If you are going to assess the breast lump in itself, go for the rule of the investigation according to the age cutoff of 30. Below 30, ultrasound. More than 30 will be mammogram. And in some other literature, the cutoff age is 35. So if a young lady, go for ultrasound. If an old lady, go for 35. This is regarding the lump. But if we have a breast implant, to investigate the breast implant itself, like implant rupture after trauma, go for MRI. But in the exam, the question will be like this. A female lady, about 25-year-old, have a lump in her breast, and she have done a breast implant. How would you investigate for the lump? we will follow the investigation rule. We are not investigating here for the implant. We are investigating the lump itself. So we will do ultrasound. This is a very famous MRCS question-based scenario and very famous record question to trick you. Don't be tricked. You are not investigating for the lump. You are investigating for the mass. Follow the rule. We are not screening here. We are investigating here. There is a true mass to be suspected and done examination with triple assessment. While in screening, we are not talking about the breast assessment. No, we are assessing the screening population according to the country regulation. And the only word for screening equal mammogram. The only exception will be a strong family history or high risk group who will require MRI to see the mini micro calcifications of the MRI. So the cutoff of a breast mass to be investigated is 35. More than 35 mammogram, below 35 will be ultrasound. This is according to the UK guidelines. Before it was 30. The trick, it's now 35. So more than 35. Female patient, no family history of breast cancer with an implant. If she is 35, go for mammogram. Ultrasound, the breast implant? No. Ultrasound of the breast mass if the patient is below 35. We are investigating for the lump, not investigating the implant. The implant, if rupture and you are caring for the implant, go for MRI. So again, a 34-year-old female patient, no family history of breast cancer with implant. How would you investigate? Of course, ultrasound. If breast lump surveillance triple assessment, so it's ultrasound. But if you want to screen this patient, so it will be mammogram. We are talking about a 34-year-old lady. So our cut-off age will be 35, not 30. I started with the 30 to destroy this concept. Because in previous ages, 30 was the cut-off. And by the way, if a 19-year-old female patient with no history of breast cancer in family and there is no implant, how would you investigate this patient? If there is a lump, go for ultrasound because she is young age. But there is no screening for this patient. A screening starts at the age of 30. Clear? So the cut-off age of screening is 30 unless there is a family history. So the same 19-year-old female patient who has a history of breast cancer in family and there is no implant, who went to start surveillance here with MRI at age of 20, only if faulty TP53 at age of 20, otherwise MRI at age of 30. So the only reason you can investigate a young female at age of 20 will be a faulty TB53 at age of 20. Otherwise, she will be screened at age of 30 because her family history breast cancer, but with MRI, not a mammogram. But if there is a lump, go for MRI for the lump assessment for this patient. Take care. To end the confusion regarding the breast implant and the lump, the recommendations of the UK is to investigate the lump, not the breast implant. But the recommendation in practice by the oncosurgeons is to do MRI. Either you are investigating the lump or investigating for the implant. Whenever there is an implant, go for MRI. But we will follow the UK regulation for MRCS exam. Clear? And again, the cutoff to screen is age of 30. The only exception is a 20-year-old lady with TP53 gene, which will require MRI. The cutoff age to differentiate a breast lump is 35. Ultrasound before 35, mammogram after 35. Clear? And again, screening equal mammogram except if there is a family history, go for MRI. Those are the broad lines, those are the rules. use them to solve any question regarding breast investigation from their triple assessment investigation questions that will come in your exam.